Hello and welcome back to another edition of GNAT-TV's In-Depth series. I'm Andrew McKeever, the news director at GNAT-TV's News Project, and it's a pleasure to have you with us today on Thursday, November 21st. It's also a great pleasure to be joined today by two folks who are here to talk to us a little bit about healthcare costs and hospital costs in Vermont. Some of you, I'm sure, have been hearing a lot about some of the financial pressures that some of the hospitals around the state seem to be struggling with. And so we couldn't think of a better way to unpack all of that than to have these two gentlemen here to explain all of that to us. With us today, joining us in the studio, are Tom D., who is the president and CEO of the Southwestern Vermont Healthcare, which operates Southwestern Vermont Medical Center. I always get the two of those mixed up, too, Tom. They have a partnership with Dartmouth Hitchcock Health Center over in New Hampshire, and Tom, altogether, has more than 33 years of experience as a hospital CEO. Tom, welcome back to GNAT.
Thank you, Andrew.
Great to be here. Also a great pleasure to be joined today by Michael Del Trecco, who is the president and CEO of the Vermont Association of Hospitals and Health Systems. He has been with the health systems for 18 years, has an extensive background in healthcare finance, public policy, and hospital operations. Michael, welcome. And thank you for making a long drive down from up north.
My pleasure to be here, and it's always great to join my colleague, Tom.
All right. Well, we really appreciate both of you making the time for this, I think, important conversation. You know, in recent weeks, we've been hearing a lot about hospitals around Vermont going through some what seem like difficult financial times. Costs are rising, revenues apparently, I guess, not keeping pace. And there may be a possibility, I guess, that some of the state's smaller hospitals might be forced to either close or perhaps curtail some of their operations. So I guess I just wondered, Mike, perhaps we'll look to you to get us started here. What is the big statewide broad picture as you're seeing it from your vantage point?
Sure. Thanks for the question and the opportunity. It's no surprise that our hospitals throughout Vermont, and there's 14 hospitals, are managing some difficult financial challenges. More acutely coming out of the pandemic, we saw significant wage pressures. We saw the need to hire travelers to cover services. And the demand and the access of care is increasing. One of the questions that asked coming out of that pandemic was, hey, how can we increase access to care and increase the services? And by way of example, we've seen about a 23% increase in our outpatient activity statewide. Our length of stay for when people are staying in our organizations is up 11 to 12%. And acuity, that measures how sick people are, is up 5%. And when you start to look at that volume and the ability for our organizations to flex on that volume with the pressures of inflation that are 8 to 10 points, we're seeing some of these financial pressures. So no surprise, you know, we have 8 or 9 of our hospitals that are operating in the red, and that leads us to the opportunity created by Act 167 on how do we look at affordability, how do we look at sustainability, and how do we do this in a way that keeps care local. You know, one of our goals and principles is equitable access to care, and part of that is keeping care local and not creating unintended consequences for Vermonters, especially in our rural areas.
Mm-hmm. So, Tom, what are you seeing from the more local level down here in Bennington County, SVMC? Is that what Mike just told us?
Yeah, what Mike's outlining is very similar to what we're seeing. You know, as you in the introduction, Andrew, you know, I've been in the healthcare field for a long time, 44 years total, and 33 as a CEO. And I have to tell you, this is probably the toughest time I've gone through in my career. And I've been at numerous organizations. And it's especially challenging in the rural side of operations. You know, we don't have a lot of, you know, the population base is limited. The fact that, you know, we're living in Vermont, which has, you know, a very elderly population compared to the rest of the country. I think we're the second oldest state in the country. The socioeconomics and dynamics, demographics of our people is very challenging. So this all adds up to a, the overused term, perfect storm in terms of what we're trying to fight through. So we have our challenges. Our hospital, financially, we're about a $225 million operation. And, we employ about 1,400 people. And we're at a, we're at a break-even point. I mean, I think we just closed our books for 2024, and we had a gain of about, $80,000. So that's, that is not sufficient to be able to do all the things that we're looking to do in terms of building our services and really building a system that allows more of our local people to stay closer to home for their care. And that's, as Mike said, that's one of the tenets of, I think, strong health care is being able to care for people locally. And that's always a challenge for us.
So in addition to the demographics piece, which I'd like to return to a little bit later and talk about some more, insurance costs seem to be one of the big drivers you're wrestling with, not just Medicare and Medicaid, but private insurance costs as well are going up. And is my understanding correct that your hospitals aren't able to kind of increase rates to kind of offset the cost of those insurance? Is that part of the problem?
Yeah, just to sort of pick up where Tom left off, being able to reinvest in our services is key. And when you have a break-even margin, you can do that 1 or 2 years in a row. But the continued reliance on reserves or savings, it makes it more problematic as you move forward. The increased costs of insurance, I look at that in many ways. I think there are 4 or 5 areas that drive some of the premium inflation and sort of set the stage. Our commercial carrier, their line item expense is our hospital's line items revenues. So the first thing that impacts premiums is provider services, hospital services, long-term care, skilled nursing, and that is an equation of price, what our providers charge, and combined with how sick people are, and then how many times do we do something. So the volume, and as I alluded to earlier, we're seeing higher volumes. So that is driving a major variable on the commercial segment. Then there are things outside of the provider setting, things like pharmaceuticals. We know the demand for things like weight loss drugs is very high. Those are $1,000+ a month for an individual, and those become an insurance company's line item expense. I think more importantly, as we go down this list of variables, we have a fractured ecosystem outside of our hospital, and that's long-term care, mental health services, skilled nursing, substance misuse services. And when those external organizations are challenged, more than hospitals financially, we often have patients that get, I'll call it, stuck in our organizations, whether it's in our emergency departments, for waiting for placement for mental health inpatient services, in our emergency departments waiting actually for a bed for inpatient hospital care, or stuck in our inpatient units waiting for placement in long-term care. That is the most expensive setting for those people to be waiting for services. And there's a few things that get added to that. There's moral injury of our staff because they know that's not the right place for these people, and this is the right place at the right time. Conversation creating, and those are creating some pressures on our delivery system and costs. The other thing, as we alluded to, is our demographics. We have a shrinking commercial pool, and when our commercial pool shrinks, we have less individuals to spread these increased costs over. So there's an economy of scale issue here. All these dynamics, hydraulics, are moving forces, creating some pressures on insurance. So lots of components. And then we're seeing our Medicare and Medicaid programs see more demand. Our aging population fall into the Medicare category, and those underserved populations fall in typically into the, Medicare for the older populations, Medicaid for the underserved populations. And we're seeing when those payers pay less when it costs to deliver care, the commercial insurers have typically made up some of that difference. All of these things are creating these pressures that are creating the financial issues that we're seeing.
And just to dovetail what Mike just said, if you look at our situation, 80% of our patients are either Medicare or Medicaid. And if you look at the average reimbursement, Medicaid covers about 50% of the cost of a patient care. So for every patient that comes in, we lose about half in terms of the cost it's not non-reimbursable. Medicare, the cost covers about 80%. So, so again, not the full cost. So what do we have to do? Actually, we end up charging more on the insurance side to cover for the losses on the governmental side. Not really fair, but that's how the system is geared in Vermont. And that drives those commercial costs even higher as Medicare and Medicaid don't increase their reimbursements to hospitals. So unfortunately, a smaller group of people, the commercial insured individuals, end up paying a larger sum of money.
I'm wondering, I mean, Vermont can't be the only state looking at this situation or in this position. I mean, Maine, which is the oldest state, we're still, I think, number 2 there.
Number 2, yeah.
In that dubious category. I mean, must be going through a similar kind of stressful situation. And I would think that there are states right across the country that are seeing aging demographics and struggling to offset or shift the cost from private insurance payers to Medicare. There must be some pressure that you all are bringing to our congressional and senators in Washington to say, hey, we have to make some adjustments here. Is that happening?
Yeah, we are not unique in Vermont. I think some of the rural nature of Vermont might be unique. Our aging demographics, as you alluded to, there are other places like Maine that has similar. So yeah, I meet with our federal delegation quarterly. I also meet with them 2 or 3 times a year in person in DC, and we talk about these things. I want to use as a backdrop the opportunities we have in this Act 167 work to address and identify some opportunities of change. And then we as a state of Vermont are always working on the next big thing around payment reform models. And there is a payment reform model that we're actively exploring with Medicare. It's called the AHEAD model. Largely what this is a global budget for hospitals and organizations, paying organizations a flat rate to deliver care to all their patients. And the idea is if we can improve the outpatient ecosystem that I spoke about earlier, we can put some downward pressure on costs. It is a constraint model, but the idea is freeing up resources, putting more resources in the community setting, allowing hospitals to take care of those patients that need hospital care and in the emergency department and the inpatient setting. So I think there's opportunity. Sometimes this opportunity comes with anxiety, and I'll even say fear for some communities because of the notion that I might lose services and local access. So all of these things come together, and it's going to take some real leadership to move through the next cycle of this work. But we're excited to embrace it.
Andrew, we're not unique, as Mike said. But what is unique about Vermont is our size. I mean, we're a very small state, and the number of services that are. I mean, I'm coming out of New York, upstate New York, in the Hudson Valley area. And the services that are available to the population there is much greater than Vermont. So in Vermont, oftentimes a hospital becomes the safety net. We are the place of last resort. And we have patients who are dropped off to our emergency room all the time because there's nowhere else for them to go, no alternative settings. So those patients end up staying in our hospital. And sometimes they could be there literally for months. And the cost is being incurred. We're not being reimbursed, and that's a continued problem we have. Is not the depth of services, alternative services in Vermont that you would see in other states, and that drives up healthcare costs because the hospitals are the most expensive place to go to. So if you don't have a primary care physician, where do you end up going? You go to the emergency room, and again. not a cost-effective place to be used for your primary care needs. And that type of problem continues to manifest itself on an ongoing basis.
Well, I wanted to ask you both about this report that came out earlier this year by the Oliver Wyman Consulting Group. I gather that was commissioned through the Vermont Care Board.
Correct.
I think it was actually part of the Act 167 that you referred to earlier. I mean, it came out with some recommendations that I gather weren't greeted with loud applause. I wondered if you could explain to us a little bit what was in that report and what were some of your concerns about it.
Yeah, let me step back here and define. Act 167 was passed in 2022, and it was around affordability and sustainability. To boil down the report, it was about a 150-page some odd report that talked about recommendations. The recommendations landed in 3 areas largely: state recommendations, hospital recommendations, and recommendations for the regulator. The state recommendations are what we were just talking about. How do we improve the outpatient access to care? And I have to hand it to my colleagues at the Department of the Agency in Human Services. They've done a lot of investing in just what we've been talking about. We have a lot of work to do. The second area is around housing and transportation. So housing needs to be improved so we can draw in and start to bring more people into the commercial population, younger people, to spread that risk out. And then again, as I mentioned, transportation. And transportation largely is in 2 categories: public transportation and then EMS transport services. So we have a fragmented EMS system, and how do we bring it together so when a transport from a rural hospital in the Northeast Kingdom needs to go to Boston or Albany, you don't lose that rig for the entire day. So how do we improve our transport system? So that's the first set of recommendations. The next set of recommendations were for hospitals. It called on 4 hospitals to essentially close their emergency departments and inpatient units. And I want to be very clear, it doesn't say the hospital is closed, but if you eliminate those 2 services, you largely close that organization. And then the couple of other things under the hospital recommendations were: how do we define and identify centers of excellence for consolidated and regionalization of care services? One of those could be orthopedics. And then the third large area was birthing centers throughout Vermont. So again, transportation is key. As we know, not everybody has a car or a car that is registered or insured in Vermont, and those cause some problems on how do we get patients to the right setting for this care. And then the final set of recommendations lived in the space of the regulator. And as you alluded to earlier, Andrew, passing on no additional costs to commercial insurers. So freeze payments, increases to hospitals, only making that financial challenge more acute. Look at reference-based pricing for Medicare. So Medicare pays a dollar amount for something, and how could we tag on to that and set up a payment amount for hospitals keying in on Medicare. And then the third is look at if the regulator needs additional support to do their work. Those are the lion's share of the recommendations, boiled down pretty succinctly. The reactions are all over the place. As I mentioned, a lot of emotion, some fear in the communities. We were concerned as organizations, was the right data used? But we're moving past that, and we have an opportunity to lean in and identify the opportunities. So we think it's good, and we think it's an important next step. I want to make sure that our listeners understand, as we do this work and regionalize services, if a patient goes out of state for care and holds a commercial insurance card of a carrier in Vermont, that expense still lives in Vermont. And if a patient delays care, that is the worst case scenario. Delayed care is the most expensive, regardless of where it's delivered. So we need to we need to move carefully. The next phase of this work is a feasibility study, and we're going to lean in on that feasibility study to make sure we, create no unintended consequences, do no harm with the focus of local care, and I think that's the next steps of this, and we will be leaning in and leading that conversation.
Did you want to add anything to that, Tom? Or?
Well, just kind of bringing the Oliver Wyman recommendations closer to home here. So our approach with them was to sit down and to pretty extensively go through our strategic plan and what we're looking to do over the next 5 years as as a health system, as a member of the Dartmouth Health System also. And kind of what Mike alluded to, our plan, Andrew, is to become much more of a regional hospital and to create services that allow patients to stay close to home. And it's very clear, the more we can have patients stay within our catchment area and go to our hospitals, it saves Vermonters money. When you compare the costs of our hospital, and we have very good outcomes. Our outcomes can compete with virtually anyone. So if the outcomes are strong, the clinical outcomes, and our costs are at the lower end, still too high, but lower end, we can save Vermonters money. So people now who travel to Albany, they travel down to Pittsfield, they may have to travel points, north. We can show and demonstrate that saves them money if they need healthcare needs. And that's what we're building. We're building services in the areas of oncology, cardiology, surgical services of subspecialties. And I think the Oliver Wyman people got it. And their recommendations very much mirrored our plans in terms of building services that we think make sense for our region. Scale's the problem. And their recommendation was to continue to work with Dartmouth to try to share services where you can, share backroom costs to help overall control the cost of healthcare. So we don't agree with all the stuff, but directionally we think they got it in our discussions, and we're supportive, and we're looking forward, as Mike said, to work with the regulators, insurance companies to try to bring this into reality. And it's not an easy journey. This is a journey that's going to take, the next 3, 5, 10 years to get there. But we think we're trying to create a roadmap that will allow us to do it.
Well, I'm wondering, it seems like, the partnership you formed with Dartmouth could almost serve as a model, perhaps, for some of the other states' smaller hospitals that maybe it just costs too much to provide some of the services that traditionally they may have been able to do in-house, but it just makes more financial sense without sacrificing anything in the way of the quality of care to have them get transported over to a place like Dartmouth or maybe UVM up in Burlington, the health center up there. I mean, wouldn't that be a feasible approach that all hospitals could take? As
I've said earlier, I've been in the field now for 44 years, and one thing I've learned is every community and region is different. And what may make sense in the greater southern Vermont region doesn't always make sense in other parts of the state or in the country. I mean, we think it makes a lot of sense for us. But, you got to look at the demographics, you got to look at the flow of patients, where they go, you got to look at the culture of the organizations that you're trying to bring together. So those are real. And I've been in deals that on paper look great, and they're a disaster. And a big piece is the culture, is making sure you can work together. Again, things, the finance accountant people always look at the numbers, which are important, but you got to make sure does it really work from a clinical standpoint, from a relationship standpoint. We think it works well with us, and it may work well for some other hospitals in the state, working with UVM as an example too, but it may not work for everybody. So I think we went through a process we took 2 years to go through a discernment review process of different partners, and then we worked together for Dartmouth for the better part of 12 years. So we developed a relationship and a track record of trust and working well together. Again, that everyone has to kind of go through that. And what you don't want to do is just force organizations together, because invariably those fall apart.
I was wondering also a couple of years ago, I remember, in fact, Tom, I think you were the principal speaker up at the Manchester Community Library about an event talking about the future of healthcare in Vermont. And one of the things I recall you saying was how it would be a good idea to emphasize wellness, just general, people just being aware of healthy lifestyles, staying well enough so that you don't have to go to the hospital in the first place, and that would be one way to kind of maybe lighten a little bit of the load a little bit. And I just wondered, how is that initiative kind of? Are you seeing some results from that? Is that improving anything, or is it just too early to tell, or just kind of the
Well,
the
I
data
think
is
what
mixed?
we are seeing, and we've done a lot of work in terms of expanding wellness initiatives, our whole transitional care nursing program, where we go out to the community before people come into the hospital to work with them and making sure they're taking their meds and seeing their doctors and following up is an example that's worked very well for us. It's been nationally recognized. But you have to also realize you can't deny the demographics. And the demographics are a little sobering in our region, probably one of the toughest regions in the state. But we intend to continue to focus on demographics, especially as we look towards a new payment reform where hospitals are given a lump sum amount of money to live within. And part of that is having a pretty extensive, preventive medicine wellness initiatives. So we're buying into it, we're going to work harder and harder on it. But there's still always going to be a need for inpatient beds, always going to be a need for ICU beds. And so we have to make sure that system is balanced, both on the wellness side, preventive medicine side, as well as on the curative side. And that's what we're striving to do.
Just to key in on that a little bit, Vermont has been a leader in so many ways in this sort of value-based prevention model. We adopted a payment reform model 7 or 8 years ago, the all-payer model. That's sunsetting. We're moving into how do we explore the AHEAD model. It's a payment model, but the underpinnings of this how do we keep the population healthy, and how do we incentivize our hospitals and our providers to do the work Tom just was mentioning, prevention, awareness of your illness and monitoring of those, whether it's high blood pressure or diabetes, and how do you make those steps outside of the home, outside of the hospital, in the home, to lower the cost of those services, so those patients don't show up. So the work that Tom and many of the hospitals around the state, it's critical, but one of the, just to underscore, demographics and the need for services is we're seeing it grow. Hopefully these two things balance out. It leads me to talking about the transformation work, and how do we move forward in this space around regionalization and looking at how we change the way we deliver care, and bringing the patients along and having them understand those changes. As we do that work, I think there's a parallel track that has to happen, and it goes back to some of the state recommendations. How do we start building one house at a time instead of 1,000s at a time? And so we do have 1,000 in a certain period, and attract people to Vermont. So the transformation has to be humming along, as well as the parallel track of growth in Vermont to put some downward pressure on these costs that we're seeing. Without those two dynamics working in harmony, I think we'll see more challenge.
And Andrew, just one more point, the linchpin of a strong wellness program is having a strong primary care network out there that can work with the patients, and that's a challenge in the rural area, recruiting primary. It's a challenge everywhere, but especially in the rural area. It's one of the reasons why we're trying to create a family medicine training program, so we can start training our own doctors and grow them locally so they can stay in Vermont. And because we have a shortage, and the shortage is becoming more acute as we go out, as more and more physicians are retiring. So primary care is a linchpin to success of our healthcare system.
So this sounds like an issue or problem that is a long-term one in terms of finding solutions, demographics, housing. I guess I just wondered, what are you anticipating needing to happen in the short term, like say in the next 6 months or to a year or so? I mean, is there something that the state government could do in just the very near future when they return to Montpelier in January that could at least sort of help you get through until some of the longer term solutions have a chance to kick in?
Yeah, it's a great question. I think I'll start by saying patience is going to be important. We have some things in motion around this affordability and sustainability work under Act 167. We'll enter into this feasibility stage. As Tom mentioned, it's a 3, 5, 10-year cycle of moving things around so we don't create harm. And we need patience first and foremost to do that work. The second thing we need to resist is spending savings before they happen. We often say, oh, this activity will save this amount of money, so let's take it from the resource that it will be saved from eventually and spend it over here. We have to resist that to make sure that these actions become proven and actually do save money. So those are a couple of things that I would ask the legislature and our partners at the state and our partners in regulation. Let's be patient and work through this and make sure the feasibility studies that we look at understand total costs of moving services, impacts on patients, and we do it in a way that's effective and beneficial as opposed to potentially reactionary. And I have confidence that we'll be doing that. And I think in the other thing that I would speak to the legislature about is how do we make sure we continue to maximize our federal money as it's available. There's a big question mark on the new administration, particularly around health care. We are reliant, the state of Vermont is reliant on federal monies to deliver health care. So what will happen? What will be the pressures with the new administration? There's a lot of question marks there. So how do we think and be prepared for that? So I'd want the legislature to be apprised of that as things unfold. And then we need to continue to do the work of having a growth model in the state of Vermont. And it starts with housing. Act 250 is part of that. And looking at reliable transportation throughout the state. And like, what is our growth model? What's our economic growth model to balance some of these challenges that we've been talking about?
You know, and again, closer to home, as Mike talks about the macro, the more the micro here is kind of sticking to our plan. I mean, we just finished a major emergency room project, which will allow us to treat more patients locally, which is critical for us. You know, we are going to start doing a cancer center project next spring, which, again, cancer care is a high cost, very traumatic service to go through, and people go to New York City and Boston for their care, which is understandable, but the ongoing, you know, for their diagnosis is very appropriate, but ongoing care can happen close to home. And that's another example why we think we can provide high quality care at a lower cost here. And another service line that's critical, and I think it's important for Vermont to expand upon, is mental health services. And we have an application in front of the state that's been there for 12 months now to open up a new adolescent mental health unit for kids, inpatient. And those are the type of things that hopefully we can activate and make a real difference in our local population. And so we need to work closely with the regulators. And as they ask us to look to save money, that's where we need them to follow through on their end of it and approve the projects that we're submitting to them.
Mm. Just one last question before we have to run. I couldn't help but wonder if the experience of going through the COVID pandemic must have been a grueling one for everyone in the hospital area. Did that impose a lot of additional costs that are kind of now coming home to roost in some way, or maybe is the big takeaway like, wow, we got through that incredible experience, pretty well, all things considered, in terms of your ability to deliver care, and now we're better prepared if we should ever have to do that again or something like it.
Yeah, well, I would agree with that. Certainly, we treated 75,000 people during the COVID time with the
That's just an incredible
vaccinations.
number.
So it was a huge number we took care of. But we're still recovering. Make no mistake about that. We are, certain costs were embedded in the system. Certainly our payroll workforce costs went up in a substantial way. And also the inflationary factors, we're still reeling from that. I mean, all our supplies, our construction costs are all, there's a new normal, and the new normal is a high normal. So that's putting a lot of stress on our system right now in terms of still trying to come to a balance. And our financials are not as strong today than they were back in 2019 and earlier than that because of COVID. So there's long-term impact, Andrew, and we learned from it. I think we'll be better prepared for the next time. But certainly it's a real and palpable impact that it's had on many, many organizations across the country.
Yeah, I would just echo and say statewide, the experience of what Tom just described is spot on. And even in some of our more remote and rural areas, that workforce piece, it was even more dramatic because we had the Great Resignation. We have workplace violence in our emergency. And so people just said, I'm going to do a different thing here in the next part of my life. And that we still are dealing with many, many of the aspects of workforce challenges day in, day out. When I talk to Tom's colleagues throughout the state and other hospital leaders, workforce is primarily the first thing I hear about. Workforce and access, and how do we make sure we maintain the right level of service for our patients is a primary goal here, and we take it as not-for-profit organizations. We take that very, very seriously.
Well, most interesting. You both have your work cut out for you, I think. Well, I guess we'll have to leave it there, but I want to thank you both again for making the time for this conversation, a really important one, I think. We seem to be hearing about affordability issues in Vermont all over the place, from property taxes to housing and healthcare, so it's important to understand what are some of the drivers of all of that, and as we work our way towards solutions to all of them. It's not going to be an easy task, I can see. But thank you again both, Tom D., the President and CEO of the Southwestern Vermont Healthcare, and Michael Del Trecco, the President and CEO of the Vermont Association of Hospitals and Health Systems. Really appreciate your time, both
My
of you.
pleasure.
Thank you very
Thank
much.
you very much,
Thank you.
Andrew. Always a pleasure.
And thanks to all of you who've been with us today. Hope you found our program interesting, and we'll see you again the next time. Take care.